I think having all those drugs, how do you, which combos do you use, what sequence do you use, and then the cost. So as you add in more and more of these new drugs, they're all expensive, and how do you pay for all of that? So there's that. There's also, we were talking about, as you're having people live longer, you're seeing unusual things like CNS myeloma, more extramedullary disease, and we're getting more of some of what were previously rare issues in myeloma, so we have to know how to treat those, and so a lot's happening. I think we're also looking at minimal residual disease, or MRD, and that's mainly in a research setting, but we'll have to see how quickly we transition that into actual clinical practice and how we change things in myeloma based on that. So can you stop therapy earlier? And if you do some of those things, that might be where there's a cost savings. The other thing is that it was kind of said that you don't need to do advanced imaging like PET if you already have a diagnosis. It's useful for smoldering myeloma to get the diagnosis of myeloma, but there's newer data suggesting getting a before and after PET, like lymphomas, looks like it may be very valuable for looking at outcomes.